In this video session, we will focus on acetaminophen. Let's start with our case. This is a 55-year-old woman who drove herself to the emergency department this morning. Yesterday afternoon, about 20 hours ago, she ingested 70 tablets of acetaminophen extra strength, 500 milligrams each. Her usual medications include quetiapine, mirtazapine, and clonazepam. Once she arrived, she was awake, alert, and oriented. Her heart rate was 84 beats per minute, blood pressure 151/85, respiratory rate 24, oxygen saturation 100% on room air, and a temperature of 36.1 degrees Celsius. She looked pale, and she reported that she'd been nauseated and vomiting throughout the night. Think about what tests you would like to order to help make your management decisions. As discussed in the introductory video to the Toxicologic Investigations section, there are a number of basic lab tests that would be appropriate to order for this patient, including basic blood electrolytes and renal function. Since this was an intentional suicide ingestion, it is important to screen for co-ingestants such as ASA and ethanol. We also know that acetaminophen is hepatotoxic, and an evaluation of liver enzymes and function would be appropriate. The lab work comes back as follows. The acetaminophen level, or APAP, which stands for N-acetyl para-aminophenol, comes back at 1,318 micromoles per liter. ASA and ethanol levels were both negative. AST was 406 units per liter, with an ALT of 453 units per liter, and a total bilirubin of 16 nanomoles per liter. Creatinine and BUN were both normal at 67 and 8 respectively. INR was 1.3. How do we now proceed to use this information to provide the best management for our patient? First, let's look at how acetaminophen is metabolized. Acetaminophen undergoes metabolism by three pathways. The main pathways are glucuronidation and sulfation, which account for over 90% of metabolism, to non-toxic metabolites that are renally excreted. About 5% also gets eliminated by the kidneys unchanged. There is an additional oxidative pathway where 5 to 10% is metabolized by the cytochrome enzymes CYP2E1 and 3A4 to a toxic intermediate called NAPK, or N-acetyl para-benzoquinonamine. Under normal conditions, NAPK is detoxified through conjugation with glutathione. However, with an acetaminophen overdose, the glucuronidation and sulfation pathways are saturated, and more of the drug is metabolized down the oxidative pathway to form NAPK. As a result, glutathione stores are depleted, and more NAPK becomes available to bind to cellular macromolecules, which leads to hepatotoxicity. Now that we understand how acetaminophen becomes toxic, how do we assess the risk for our patient using the laboratory values we have? The Rumack-Matthew nomogram has developed to predict the risk of hepatotoxicity based on the serum acetaminophen level. It has been validated for levels measured between 4 to 24 hours post-ingestion. There are two lines, one for probable hepatotoxicity and another lower line for possible hepatotoxicity. Any level above the possible hepatotoxicity line should receive treatment with the antidote for acetaminophen. This nomogram can be used for acute single ingestions. It cannot be used for delayed presentations greater than 24 hours post-ingestion or repeated dose ingestions. It is also important to recognize that an acetaminophen level that's been drawn before 4 hours post-ingestion needs to be repeated at the 4-hour point to use the nomogram. Our patient had a level of acetaminophen at 1,318 micromoles per liter at 20 hours post-ingestion, a level well above the possible hepatotoxicity line. What next step for treatment for this patient to treat the acetaminophen overdose? N-acetylcysteine, or NAC, is an effective antidote for acetaminophen toxicity. NAC prevents hepatic injury primarily by restoring hepatic glutathione stores, as well as through some other mechanisms. NAC is over 95% effective at preventing hepatotoxicity when it is given within 8 hours after an acute acetaminophen ingestion. Although the risk of hepatotoxicity increases with a delay in the NAC administration greater than 12 hours post-ingestion, there continues to be a benefit even with delayed presentations. Our patient is started on N-acetylcysteine treatment and has follow-up blood work done which shows progressive hepatotoxicity. Her peak AST and ALT levels were greater than 12,000 and a peak INR was 3.7. Here are some questions related to acetaminophen toxicity in our case. What are the stages of acetaminophen toxicity? What are the complications of oral and IV N-acetylcysteine treatment? And what are the indications for liver transplant following acetaminophen overdose?